I think we'll just get started at this point. Please feel free to ask any questions or answers in the Q&A panel if you have any throughout, and we'll be answering them at the end. So I'm just going to jump in. So today's topic is about the hidden value and cost of unstructured data. And so today it will be myself. So I'm Michael Millar. I'm the CEO and founder of Verto Health. I also teach health informatics at University of Toronto for a number of years and just an absolute health informatics nerd, I guess. Michael, maybe a quick intro from you.
I am Mike Anderson. I'm both a surgical oncologist and a palliative care physician, and I work in healthcare leadership, both in institutional and community settings. I'm the Chief Medical Officer for Verto. So thank you.
Okay, so we're going to jump into the topic at hand. So you've obviously come here because unstructured data is something that you want to learn a little bit more about, but it's a topic that's coming up more recently, especially with the advent of AI. And so unstructured data is commonly defined as data that's not readily available in like tables or structures that you can access specific data formats in, right? And so when you think of this, if you think about a clinical note or a raw dictation, these are examples of unstructured data or unstructured text. And an interesting thing about it, and I've provided the link to an article that talks about it, is you always hear all the time in healthcare, we have so much data. There's so much data in healthcare. A lot of that, actually a majority of it, is trapped in this unstructured data format. So when you think about notes about a family history, social determinants of health, conditions, all that information, it's actually readily stored in these unstructured text blobs. And, for humans, that's not a problem because we can read it, we can understand it. But from a digital perspective, that is a big blocker. So, Michael, maybe just some examples of unstructured text that you work with.
Yeah, the vast majority of what we work with clinically is unstructured, whether it's clinical notes in a narrative form, procedure notes, but then you start to bring in all the other things, discharge summaries, pathology reports, imaging reports. That's before you even venture into the space of all of the images and videos that we collect within EMRs. The vast majority of things are unstructured, and it's a profoundly rich source of information. In fact, a couple of groups have looked at how much information you miss if you don't include the unstructured, if you only look at structured information. And it's to the order of you miss something on the order of 40% of services delivered. You capture almost no social determinants of health. And if you try to case find based on disease states, you miss at least a third if you aren't looking to the unstructured data.
Okay, so if we've answered what unstructured data is, then we need to talk about what structured data is, right? And so in the healthcare context, structured data is information that's organized in a way that makes it easy to search or analyze. And the big thing here is computers and digital systems and AI primarily operate off of structured data. So they need to see specific codes for diagnoses. They need to see actual data marks, the specific numeric values in order for them to have that. And when it comes to structured data, there's like generally three kind of qualities that you're looking for, which is that it's organized, it's standardized or normalized in some way, and then it's accessible through a digital or a direct means. And so when you think about a raw dictation note, that's not really something that a computer program can necessarily read effectively. The interesting thing about this is digital solutions are built on top of this structured data. Digital solutions don't want to operate off of data that is uncertain or could be contextually interpreted in different ways because they don't have the clinical decision-making capability to make that decision in that moment. But structured data is also useful for humans as well, right? Like if you're sending over a referral form, you don't want there to be ambiguity or confusion in a certain field or a diagnosis. And so there's some incentive, even when it comes to traditional healthcare operations, to send data in a structured format. Michael, anything to add?
Yeah, I mean, and the practical reality as a clinician is you're constantly working and amalgamating in your mind structured and unstructured data. Functioning within a healthcare space means you're working with both. I don't know that we always think of it so clearly that way, but we are.
Yeah. Okay, so hopefully this creates a foundation so that, when we say unstructured and structured data, that people aren't confused. But I'm going to throw one more wrench into that equation. You've heard of semi-structured data. So what is that? And I think an important thing to remember when you're talking about data is just information, right? How you present and store that information is what determines whether or not it is unstructured, semi-structured, or structured data. And so I've given just a simple format here of what an unstructured note looks like. So over here, it has basically the dictated note by Dr. Smith. A semi-structured looks structured because you've actually put it inside those different areas. But you'll notice that the name Lisinopril or the fact that the route is oral, although it's stored there, you don't know if those are 100% the exact same meaning across it. And so sometimes even computer systems are nervous because for the medication name, you might have spelt it wrong, right? So how does it know how to operate? Does it recognize that? And so if you look at structured data, it gets to this place of like zero need to trust. The data is explicitly defined as a code within a terminology set. So structured data gets to the point where no matter who reads it, they'll be interpreted in the same way. And so this is kind of the evolution of data that you see in healthcare. Now, Michael, quick question, like how often do you work with structured data in that format?
Do I work it in this format? Not as often, not all that often. And in fact, the pragmatic piece of it is, as a clinician, I do not enter a whole lot of structured data. In fairness, and part of that is the work to enter structured data moves the work on to me. I have to look up codes. I have to look up this stuff. It's not intuitive. So the reality is, I don't know, the real truth is most of what I generate is probably unstructured data, and some of what I consume is structured.
So I think it's important to remember, and this is all just foundation setting. When we're talking about unstructured, semi-structured, and structured data, we're talking about what is at a high level the same information. But you'll notice that as you move from unstructured to semi-structured to structured, there's certain things that become more specific and there are certain things that are lost. But we'll talk about that a little bit more later on. So where do we go from here? So I think the one of the things that we wanted to talk about in today's webinar was to help people understand that digital health doesn't actually operate off of all healthcare information. People told me that acute care had structured data. How would you take that statement, Michael? Does acute care have structured data?
Maybe, sort of. Um,
I'll put you on the spot. But
yeah, I mean, we sometimes have artificially structured data in some senses. I mean, I think it's important to go backwards to, why do clinicians document? Because that's where you start to see the gap. I was taught, there's a few principles of why you document. One of them is a note to your future self. One is medical legal, another's for billing. And the last is communication, communication to others. And at no point in any of those do they lend themselves to me structuring the data. Like, there's nothing implicit in the reasons I am expected to document that equal I will structure the data, or that structured data is more valuable to me. So there's a disconnect between what the digital health system needs and what I am incentivized and valued to produce.
yeah, I think that's a great point. Digital health data actually doesn't want data to change context. It wants to know that when it receives a patient record, that data is true in any context so that they can use it for analytics or they can use it for robotic process automation. There's an inherent bias in digital health solutions where we actually if there is context, we want it explicitly defined, right? And then if there's data, we want it explicitly defined as well. And so in order to power every single digital health solution, so if you're thinking about automated education reminders, appointment reminders, surveys, clinical decision support, reporting on analytics, the lifeblood of that is this objective, cold, structured data to power all of these digital health solutions. But then when you compare that to what clinicians want, it's a very stark different reality. So maybe just help me understand how that data is used inside different environments for you, Michael.
Let me go to something as simple as if I order a prescription for someone, the structured part of the data will show the drug, the dose, the frequency, but no part of that tells me my clinical reasoning, why I've started this, what's the rationale, what's the duration. I also lose all the nuance of the medicine is imprecise. The vagueness, the nuance is not collected in a structured data field. So for me to unlock the most value, I actually need both of them working together. And when I think about what I'm trying to convey to another clinician in communication, I'm trying to convey meaning. And so at the root of it is I'm trying to effectively convey meaning that really needs both some structured and some unstructured data to do that effectively right now.
Yeah, and so like basically if you're making a discharge summary or if you're doing a referral or if you're doing a consult, then the exact same patient would have a very different context in all three of those scenarios.
Correct. Yeah.
Okay, yeah, and so the thing here is that ultimately the EHR though, depending on who you talk to, right, serves a different purpose. So if you're talking to like an administrator, or if you're talking to a person who's doing like coding for cost recovery, they look at the EHR kind of as a legal record or just a document of what was provided. But when a clinician opens up an EMR, that's not the same context that they're looking at that, right?
Yep. I
So
have different needs that if I document it the way a data scientist would prefer me to document, I will lose so much important information that's relevant both to myself and to other clinicians and to providing good care. So, the challenge in my space is I routinely am asked by data teams to convince my clinicians to document differently. They want the clinicians to document in a structured fashion to make the data side easier, but it does not work with the clinical workflow, with the way clinicians relate, and the loss of information if everything was structured from a clinician's perspective is substantial. Furthermore, practically, I'm going to be dead honest. Every colonoscopy I have ever done in my life has been billed as the same ICD code, although we all know I do them for 100 different reasons because I can't remember the subheadings of the ICD code. So if you look at a lot of clinicians, we end up using a very narrow band of ICD codes that have a tremendous loss of information. So for me to go and accurately code is asking a surgeon to become a data scientist, and that's not my job.
yeah, and that's actually the lead in, right? The lead into our next slide, which is everyone talks and is so excited. Like it's the hype on digital health for the last 5 years has been insane. And then, but no one asks what powers that digital health revolution. I remember it was just one day I was sitting around and it was a new student and they were just like, how do you get structured data? And I didn't think about it before then. But then I was like, well, a clinician puts it into the EMR as a structured data field. And the student asked back to me, they're like, really? So it's all just human beings entering the structured data? And I wanted to say no. I wanted to say no. I'm like, no, 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 that can't be true. But then everything I thought about, the diagnoses, the medication, every single field, the immunization, it's not like you have a smart injector that goes in and it automatically puts that into the chart. It's a clinician actually documenting something in a format that they don't even want to document it in. Maybe can you talk a little bit about that? Because that's a crazy paradox to me, where we want to help physicians, we want to help clinicians make healthcare better. We want to drive the quintuple aim, but we're building every single part of that digital ecosystem on top of a manually transcribed structured data node.
Yeah. So trying to change clinicians into data scientists has been an abject failure. So when I document in any EMR, and I have a couple of workplaces, so I use different EMRs, they fundamentally are all the same. The body of how I document and how we train medical learners is in unstructured narrative. So the bulk of what I capture is an unstructured narrative. And then if I'm going to structure the data, I'm asked to then do double duty and take what I've put in a narrative form and intentionally populate it into structured fields. And that just about doubles my workload. So the notion, I'll back out a little too. I'm old enough to have been in the days where we documented in paper and switched to electronic. And there was a real crisis at the time where we were being asked to always double document. I want you to document in the paper system and I want you to document in the electronic system. And that made zero sense to most clinicians who are underwater, and administrative burden is sinking us. And so to ask clinicians to continue to double document, which is really what you're doing. I need your narrative unstructured note, and then I want you to become a data scientist, a data entry clerk, and structure that is taking a part of the system that is overwhelmed, we're undersupplied, and asking us to do work that we see little value in personally. I would also add that almost the value of structuring it rarely comes back to you as an individual clinician, that you get a feedback loop that says, this is worth my while to do. It's not to say it's not worth the while to do, but on an individual level, I don't derive benefit that pushes me to do it or that incentivizes me to do it.
Yeah, and that was one of the parts that it was actually one of my blind spots when I entered into health informatics, right? I believed that these EHRs were structured data, and that the structured data and the way that you deliver care was so normalized that it was better to receive structured data to deliver that. Like, I'll give you an example. If you're on Amazon and you're delivering a package to a house, having an explicit structured address, an explicit time that you have to go there, an explicit size of the package is very beneficial for both the worker as well as the administrator. But what was completely surprised at in healthcare was that the data that you needed to provide the best care for each one of these clinical pathways was at such odds with the data that you needed to administer that pathway or to do research in that pathway. And when I realized that the type of data that each one of those services needed, it really shocked me because it made me realize that we can cause harm as we deploy these other secondary use mechanics within healthcare. And not only can it already has. You know what I mean? It's already created this burnout. I should put the stat here, but it's such an obvious one where people say they spend up to 50% of their time just doing documentation.
And a recent Canadian study found that administrative burden and digital tools contribute to burnout, or are significant, if not one of the leading causes of physician burnout. So the challenge is these tools that should be enablers also have a significant cost to clinician well-being.
But the whole thing is, I guess one of the things that we wanted to bring up in today's webinar was just this awareness that you know there's suddenly this huge push for mass automation, like robotic process automation. It's not a new topic, but with the new hype around AI, there's this huge push for more standardization, more robotic process automation, more clinical decision support to support these AI and automated capabilities. But still, at the end of the day, these systems are built on structured data. And so if we use the current pipeline, which is clinicians being forced to put in more structured data, it's unsustainable, right? It's not something that we can rely on. And it's something that we need to think about as part of the value, right? Because whenever I see digital health studies, they don't look at the digital burden to create the structured data. The benefits that they have are only looking at one side of that data ecosystem. They're not looking at the what did you have to do to change clinical process in order to enable that benefit, right? And I think that it's one of the things that we need to bring into the dialogue, which is here's a digital solution or an AI solution that you're bringing in. What is the actual real cost to the system to set up the proper data environment for that to create its value? What do you think about that, Michael? Like, do you think that that's not something that you hear in conversation that often, right?
No, I mean the notion of being practically integrated into workflow it's talked about a lot, but it's not actioned, doesn't follow through often. So there is a divorce between what the practical workflows are and how digital tools integrate into that workflow.
Okay, so again, let's move on from doom and gloom because this is kind of where it changes into a bit of a call to action, right? Where we say, instead of only focusing on technologies that can actually help on the other side of structured data, there are ways that we can bring better structured data health collection into the process with technology, right? And so, this is the kind of area that I feel a lot of people under focus on. And so we already have it, right? We already have four approaches. There's more than these four. These are just the four that come to mind when I was talking about this problem, right? And so I'll go through each one of them and I'll just talk and then give examples of how they're working in reality, right? So one of them is trusted interoperability. Now, it's a sad thing that I have to qualify interoperability, but I feel necessary to do that because people use interoperability pretty loosely. But trusted interoperability is the ability to exchange structured data from one clinical location to another where that trust is maintained. Right? So like Michael, like when you get sent a referral, would you make a diagnosis off of the data that you receive in a referral?
Not a chance.
So, like, that's an example of the difference between interoperability and trusted interoperability, right? That being said, you've worked in diagnostic clinics. If you send to the diagnostic clinic and then you're able to send the actual lab report and the actual diagnostic scan and the actual pathology on a biopsy, now can you work off of that data?
Absolutely. I trust it. Right.
Yeah, and so that's a concept, right? And so what we need to do is invest. We need to understand that integrations aren't enough. We need to actually create interoperability so that that structured data has relevancy in the new clinical setting that's moved to. So this will reduce redundant scans, redundant procedures, tests, while also reducing the amount of manual transcription into structured data. So this is one way. I know that we've worked on interoperability, but digital health needs to hold ourselves to a higher standard where we have to have that trust being intact between the sender and the receiver. So then the second one is medical devices and sensors. So creating more integration. So this is the integration of smart beds. So this is one thing that completely shocks me. Almost all these hospitals, they have smart beds, but the smart beds are very rarely integrated into the EHR, right? Like what's with that?
You're not wrong at all. This is just an opinion, but until we sort out some of the signal to noise problem in healthcare data, I'm always challenged by just adding more data to the mix where you're adding both a lot of noise and a little signal.
Well, that's actually the answer, right? The
Yeah,
answer is that they emit everything. They emit, oh, this patient moved, this patient has this. We detect moisture. There's a pressure point here. At some point, you get signal overload. And so, what we need to do is become smarter about what data that our medical devices actually send into our trusted structured data space. And so, getting that signal to noise is the exact reason why there isn't adoption on this, right? Because the number of people that effectively use personal devices like smartwatches to manage their personal health, it's because they're able to filter out that signal from noise. We need to make sure that our devices contribute to the structured data equation, not overload it or drown it in that domain as well. Right. And that's actually a good point where structured data is not always good, right? Just streaming data from a smart bed is literally the scariest thing to some physicians, right? Like, now do I have to interpret this? Another one is patient generated health data, right? And so what we do in an administrative process, so I use e-referrals as a good example here, is that the full burden of a transfer from one clinician to another is put on the clinical team, right? Whereas when you think about it, we can really rethink. If a physician knows that a patient needs to go use a service, why can't the patient provide that information for that service in terms of the time, where they want to go, and family history? A lot of times, there's actually data that's lost, or there's self assessments that we could incorporate into the cycle where we can consider, can we use the patient as a source of data as opposed to only forcing it to be provider source structured data? And so this is another way that we can evolve the way that we think about how we deliver care instead of only forcing provider based data as a source. And then the final one, which is kind of like the technology moonshot, full disclosure, this is a space that we like playing in, which is using AI on the left hand side of creating structured data as opposed to using structured data. So, as AI advances, NLP advances, its ability to read through contextual unstructured data and pull out clinical structured information is now a feasible capability. It's already being done in many different areas, but instead of focusing only on digital health consuming structured data, now we're in a place where we can actually use AI agents to help create more structured data. And one example of a missed opportunity, but maybe not a missed opportunity, is AI scribes, for example, right? AI scribes have taken the unstructured data that is voice and converted it into unstructured text, but they can also go one step further and actually help automate the extraction of structured text from that voice as well. And so this is an area of opportunity where we can think about how technology is used to help create that structured data. Any thoughts on that, Michael?
So if I'm thinking of a typical digital record, there's already pre-populated structured fields, but they're heavily loaded to, say, physical medicine, or there's certain domains they're heavily loaded to. And one of the things we find is there's very, very little structured data around social determinants of health, psychological conditions, social supports, a lot of nuance that is relevant to healthcare, but is a little outside of what we might initially term clinical medicine or physical medicine. But those things are so crucial, and they're almost never stored in structured fields. And yet, if you want to take a population health approach to managing people, to looking at groups of people and how you can manage them and target interventions, you have to start to know about all of this unstructured information that currently doesn't actually even have a structured field. I think sort of dives down to the notion of we often don't know what we don't know.
Okay. And that actually brings us to the last slide of our webinar today, and a kind of call to action, which is, let's think about how we power the next generation of digital health technologies. And so, I think that one of the big things is it's so exciting what AI can do, like what advanced digital health can do, consumerize entire areas. And to be honest, digital health is a key component of solving this HHR crisis as we go into. But I do think that we need to understand how we contribute to the HHR crisis at the exact same time. And so the call to action is more, think about the whole cycle. Who is observing the data? Who's collecting the data? How are you converting that into structured data to empower digital solutions? And to think about how we can remove the collective burden throughout that entire process. Personally, I believe that the truth exists in unlocking the data that's within unstructured text. And that's kind of what we obsess about doing at Verto. And we're primarily working in the last two areas, which is both the ability for patients to be able to enter in that data directly into systems and processes, as well as AI-based NLP to help clinicians automatically extract that structured data from their day-to-day processes. So with that, it brings us to the end of the presentation. We've got a few questions in chat, so I'm going to just go through a few of them. First one was, can AI help in processing and standardizing the data for community and primary care data? What are the limitations? That is a great, great question. So I'll start off, and then Michael, if you can just build on some of the challenges with the way that data is stored in primary and community care. But I'll start off with saying primary and community care. It's interesting because there is a correlation between the amount of structured data and the amount of digital health automation that there is in each sector. And so when you think about primary care and community care, there isn't a whole ton of automations and digital health capabilities that are available in those sectors. At least in Canada, it feels that way. And as a result, there really is no incentive other than analytics and secondary use for heavily structuring that data. Maybe also billing, right, is where it's predominant for coding diagnoses. But maybe Michael, if you can talk a little bit more about that. Where's a incentive lacking in those sectors?
Yeah. If I were to think of, I work in both a hospital and a community space. So the hospital space is far more financially sound or far more resourced. So the first challenge is how much resource is available in a lot of communities and primary care sectors. But there's definitely less. But I think the need is, in fact, even greater, because if you take a collection of primary care clinicians, they actually can deliver public health. They can deliver health to their roster, but it's exceedingly difficult to understand. Actually, this morning I challenged a group of primary care clinicians that they, on one-on-one basis, they understand their patients well, but as understanding their roster of 2,000 patients, they don't. So at an individual level, I can sit there with you and I know you well. Do I understand my practice? It's very hard to do with our current technology, and yet delivering good intervention. So making sure appropriate people have vaccinations, making sure people have appropriate screening. There's all sorts of interventions that are hard to standardize in a primary care setting currently, but it is most certainly achievable.
Yeah. So, and I'll talk a little bit from with the actual Verto hat on, but because of that focus on one-to-one understanding, that's actually part of the reason why there's so much unstructured text, because it's notes to your future self, right? It's notes to make sure that you're documenting correct timestamps, and so that's usually unstructured text. And so what we do is we're obsessing about how do we create smarter AI to read that type of contextual note and convert it into structured data so that they can do those new things with it. And we're not the only ones. There's quite a few people that are looking to do the same thing. But I do think that primary care it actually has such a wealth of information, population health information. And I do think that that's one domain where the AI based NLP does have a strategic advantage in really changing the game in a big way. I have one other question. What type of data is something like a fax? Okay, so this is good. From a digital perspective, the question is, it's interesting because it's called binary data, but OCR, which is optical character recognition technology, is very effective at converting fax data into an unstructured data or like a report. And so once you change it, so everyone who works in Ontario knows about Hospital Report Manager. Literally, its primary role was to convert faxes into unstructured data notes that get sent to an inbox directly. OCR can do similar capabilities. And once you get into unstructured, many of the techniques that we've talked about are relevant and useful for that.
I used to think the communication, that question around facts, I used to think the challenge in healthcare was the number of times we would flip between analog and digital information in the same process. But now it actually starts to be trying to figure out the game of how, in those processes, where are we flipping from unstructured to structured data along the way? It's funny, the thought I used to have a decade ago has shifted a bit.
Okay, there's one more question that came in. Has Verto seen any measurable improvement in clinician satisfaction as a result of this approach? Um, that's a great question. And the interesting thing is by focusing on primary care, uh, there isn't really a change because they never would have gone through their unstructured text and structured it. Like for them, it's more about unlocked capabilities. So, as Michael was talking about, the ability to look at their roster and actually do analytics on it, that has been the number one unlock that they've been able to do. But we're early on our in our journey. Like our first step of our journey, we're focusing on just reliably and in a trustworthy way converting unstructured text into structured text. And then next, what we want to do is build automations and convenience features into domains that normally haven't been able to access it, like primary care. Anything to add there, Michael?
No, I think that's actually captures it pretty well.
Okay.
Yeah.
And then we have one last question, and I'll leave it here, which is on average, how much time do AI scribes save for a primary care worker? Actually, this one I'll refer you to. We are not the experts, so they did a great study on AI scribes. It was jointly done by Ontario MD with eHealth Centers of Excellence and Weave. And so they've published that online. Would like you to point to that because the thing is everyone's looking for hard value and there were hard time value, but not it isn't in the obvious areas where you think that AI scribes actually provide the value. So I would very much point you towards that report. Um,
And I'll say I've done polling of my colleagues to see where they're actually in use, and it's a lot more limited because there still are a few concerns and cost concerns. So certainly in a primary care setting, there, the adoption is not. There isn't a high degree of adoption in sort of the real world yet. I see lots of enthusiasm from early adopters and people who are highly invested. I'll state my concern about them, which is, my personal concern is until we get to the point that my concern is we're just dumping more unstructured data in to big data lakes and adding more and more and more. And AI scribes fundamentally right now enter unstructured data. So I'm always concerned about that challenge of just adding more noise, more noise, more noise. But that said, I think when they're connected into a bit more of a process, to me, they seem like they'll unlock more value when they're connected into a more effective data management stream rather than just pushing in more unstructured text.
okay, we have 2 minutes, so I'm going to take the one last question here, which is what are the barriers to using NLP AI agents to help overcome interoperability constraints within EHRs used in the community? And as an example, so that you can do the international patient summary as Canada Health and fully implemented. So that's a great question. That's pretty targeted. To be honest, that's our exact sweet spot. Our goal and our vision for converting unstructured data into structured data is to maintain trust in that conversion. And once you're able to create that trust so that people can link the unstructured text and validate it against structured data, that they will think about how do I use this for interoperability and automation. And so, what you just described is that's actually amazing that you asked that question, but that is kind of our moonshot and our vision, which is to convert that data into an interoperable record that can now transfer the trust through interoperability mechanisms to other systems through the IPS. So, great question. Okay, that brings us to a close. Thank you, everyone, for attending. Thank you for tolerating the webinar format. We're going to be posting a follow-up, maybe a video or some summary on LinkedIn. So keep your eyes open and have a great day.